Thank you for this opportunity for me to present and actually debate against Dr. Ed Loftus. So I'm quite excited to talk to you about why you should not be doing therapeutic drug monitoring with your anti-TNF therapies. All right, so in any debate, we know there's pros and cons to everything. And the pro is whatever Dr. Ed Loftus says, he's from Mayo Clinic and you probably was going to believe him. But the cons here is that it's actually quite expensive. It takes time to get these results back. There's not a point of care testing. And you really don't need it to make medical decisions because, after all, we're physicians. We know how to manage our patients. It's actually, and I'll prove to you that it's quite useless. I was actually going to drop my mic here and leave the stage, but I figured I wouldn't want to waste this opportunity to make fun of Ed. So this is Ed Loftus the Great. He hails from Mayo Clinic, and you're probably believing everything he said. But I'm here to tell you, he's actually giving you fake news. And why is this? Well, he comes from this little town called Rochester, Minnesota. They barely have over 100,000 people there. Half the people actually work at Mayo Clinic. The other half are kids going to school. So he essentially lives this bubble life of looking at clinical trial data, looking at papers. He doesn't really deal with the real world here, okay? And the real world looks like this. Right? So as you can tell, we have a little, better breadth of knowledge of what we do, and even taking care of IBD patients. Okay, so I'm here to present to you alternative facts. And first, in order to win a debate, I have to actually stroke everyone's ego in the audience, right? So I want to tell you guys that we're as physicians, on the IQ scale, we're the smartest people in the world as far as occupation is concerned. It's true based on IQ testing. So why do we need lab tests to do what we need to do? We've spent 10 years after college going through med school and training and rest fellowship and all of that. So we really do know how to take care of our patients. And why would you want to delay treatment? It takes about a week to get the results back. You need to your patients are suffering, you need to take care of them right away. And why, oh why, right now, would you want to increase healthcare costs? These lab tests are quite expensive. And there are other golden rules in medicine, too, that we should follow, right? We've learned from medical school, treat the patient, not the lab. And of course, if it's not going to change your management, don't order it. Okay. So I'm going to give you a few clinical scenarios where TDM is actually futile, failure of biologic class, medication reaction, timing of loss of response, and drug-unrelated complications. So I'm actually going to do real-world cases here and not show you some minor data with all these numbers and complexities, because we really are taking care of these patients on a day-to-day basis. So to take a 34-year-old male with chronic Crohn's disease, previously treated with adalimumab, certolizumab, and now on infliximab 10 milligrams per kilogram every 4 weeks on weight-based full azathioprine dosing, and he's coming to you in a flare stating that really none of these medications have really helped. You confirm active disease on colonoscopy. There's really no fibrostenosis, but really active inflammation. What are your next steps here? Would you check infliximab levels and antibodies like Dr. Ed Loftus saying we should do? Or really discuss the option of ustekinumab or vedolizumab, another mechanism action agent? Well, the simple answer here is why bother checking levels? You want to move on to a different mechanism action agent because this patient's failed all 3 anti-TNFs in FDA-approved category for Crohn's, and really checking levels or checking for antibodies is going to be quite useless. You move on. Let's take a case of medication reaction. You have this female coming in with ulcerative colitis who failed azathioprine, full weight-based treatment. It's there for actually injection training and receiving her first induction doses. There's 4 pens during that time. After 3rd pen, she actually develops hives throughout her body and feels like her throat is closing in. So of course, we didn't give the 4th pen, and you stabilized her with medical treatment, and her symptoms resolve. what would you do next? Would you check for adalimumab antibodies? Well, no, it doesn't make sense. She just started induction therapy. She's not going to have developed antibodies that quickly. This is most likely a hypersensitivity reaction to the drug. You really are going to say she's allergic to it and move on to a different mechanism. So here, no antibody testing or level testing. You move on to a different mechanism because she's allergic to the drug. Now let's take an example of loss of response. You have a 69-year-old male with ulcerative colitis at 5 milligrams per kilogram infliximab every 8 weeks, and he states that he's doing well until recently, 1 week prior to his infusion. He's noticing more joint pain, some increase in frequency of his bowel movements, and after he receives his infusion, his arthropathy resolves, his bowel movements are more formed and less frequent, and feels he has more energy. So what would you do next? Would you check his infliximab levels 1 week prior to his infusion when all the symptoms start? Well, you could consider doing that, but in real life, well, what are you going to do despite what the levels show, right? You would simply increase his infliximab frequency from every 8 to every 7. It doesn't really matter if his levels are low or high. You're going to go ahead and do that, and the patient's going to be happy, and he'll feel well, and he'll thank you. You'll continue every 7-week infusions. Now, let's take an example of factors unrelated to inflammation. You have a 35-year-old female, Crohn's, for 14 years. She's underwent 2 ileoclonic resections and primary anastomosis 6 and 10 years ago. And only recently was she started on certolizumab. And so she presents to you with acute onset nausea, vomiting, and of course you order some imaging, and MRE shows fibrostenotic disease. And you confirm this at colonoscopy, where you see a significant stricture at the ileoclonic site. Well, what would you do next? Would you check certolizumab levels or discuss need for actual treatment, endoscopic dilation, or resection? And checking levels here would be futile because she doesn't have active inflammation. This is fibrotic disease from untreated disease for so many years when someone who's had fibrostenotic disease for so long. So here you would actually move on to do endoscopic, actually this patient underwent endoscopic dilation, and she felt clinically significantly better after that because you treated the problem and not treated drug levels. Okay, so you take another example of other disease-related factors. You have a 42-year-old male with UC and an endoscopic remission, but he gets diarrhea after some antibiotic use. So here, you wouldn't want to be checking levels. You actually check for C. diff and rule that out and treat underlying infection. Here, someone who's having symptoms doesn't always correlate to disease activity. It could be unrelated factors. Okay. All right, so as mentioned, there are some challenges to TDM. We don't know what is true therapeutic drug level for every one of our patients. We know that it may be higher in patients who have fistulizing disease, larger extent or significant inflammatory burden of disease, those with low albumin, perhaps male gender. And we all know that IBD is quite heterogeneous, so it's not a one-size-fits-all and not a one trough level fits all for these patients. So that's what we really don't know with all these other prior trials. I want to also include this case, and he didn't really mention this, transient antibodies. That's really not mentioned much in the literature, but to give you an example of a case of a patient who's young male, 18 years old. He was on 10 milligrams per kilogram of infliximab every 4 weeks for the past 5 to 6 years, and was doing quite well. And proactively, just to prepare myself for this talk, to do some proactive monitoring, I decided to go ahead and check his levels and see what they were. It came back as 34, very high, and I'm thinking, oh my gosh, this is quite high. We talk about levels of 3 or 7. We should consider moving him down to every 4 weeks so he doesn't have to come in very frequently. Sure enough, again, proactively, I started checking this again. His levels went down, and he developed some antibodies, and of course, him being 18 years old, his mom was in the room and crying about, oh no, I have to switch to something else because he's been doing so well on this medication, now he has antibodies. And I said, well, let's wait, let's move him back to every 4 weeks, let's recheck his levels. And sure enough, it went back up. Antibodies went away, so he really had a transient antibody response to this changing this frequency, but it didn't really lead to any poor outcome. He was able to continue his medication. So if you really only looked at levels, you might think you need to move on to a different agent, but we were able to keep him on the same therapy. Now you might wonder, gosh, 34 is such a high number. Isn't that going to be deleterious or cause issues in his health consequences? Well, there actually was a study just presented at DDW that high levels of infliximab is actually safe. They had 180 patients. They looked at levels looking at different ranges, and what they found was actually there was no difference in major adverse events especially serious events in those who had high levels versus low trough levels of infliximab. What they found, interestingly, was there were actually less adverse events in patients who had high trough levels, and even serious infections was the same, and also less infusion reactions. So perhaps we shouldn't even be considering 3 or 7 as a trough. Maybe we should be considering even higher levels for infliximab to be considered safe, and also reduce infusion reactions and safety even. Of course, Dr. Loftus brought up the TAXIT trial, and what he failed to mention to you was the actual primary endpoint. He mentioned some sub-analysis information about maybe some Crohn's patients, tend to do better, but actually if you looked at the ulcerative colitis patients, which you saw in his graph, but he didn't point out that there was really no difference in TDM versus clinical based infliximab dosing. And the primary endpoint of the study was clinical remission at 1 year, and it was similar in both groups, clinic-based versus clinically based dosing versus TDM. Okay. And I want to explain some other studies that show that trough levels in ATIs are actually useless. This study looked at patients who lost response to infliximab therapy and looked at levels and looked at who had modification in their therapy, their dosing or frequency, who were switched to adalimumab, or those that did not do any modification at all. And what they found was, of course, if you didn't do anything in someone who was not responding, well, not a lot of patients did better. But those that intensified the infliximab treatment or changed to another anti-TNF did quite well. There was no major difference between the intensification group or the changing to adalimumab group. So regardless of what you did for levels, if your patient's not doing well, if you switch to a different therapy or do something, modify their disease treatment, then they'll actually get better. And in this study, they found that looking at trough levels was actually useless because it didn't matter what the trough levels were, who responded to infliximab intensification versus who did not. And they cut down the trough levels to different quartiles here, lower quartiles. Again, it did not make any difference on who improved. There was another proactive study looking at 107 patients in an academic center. What they found was, sure, if you develop antibodies to a drug, you're not going to have as much drug level on board. But what they found was ATIs were not associated with relapse. So why are we even bothering checking in someone who's actually doing quite well? So those were all some studies in academic centers and all of that, but there actually was a study looking at the real-world experience, doing TDM in the general community gastroenterologist to see what was really going on. So they looked at patients who were not really responding, and they did TDM, and some of the physicians made an appropriate decision, like the algorithm of if the drug levels were low, then you dosed, intensified the drug, and some did an inappropriate decision of if the drug levels were low, instead of intensifying that drug, they moved on to a different agent. Regardless of what they did, there was no statistically significant difference between who actually went into remission in an appropriate decision or an inappropriate decision. Interesting, huh? Now, if you look at who actually had active disease, this percentage of who went into remission was even tighter, didn't really make any difference at all. So the question comes up to, well, why is there poor adherence to even evidence-based TDM decision-making here? And this is real world, right? So is it because we have other drugs available that if you're failing it, why bother checking levels and optimizing it when you can really move on to a different agent? And how do we really interpret the data? I showed you how useless ATIs and levels are. So if you're not going to check it and you're going to move on to something else, why bother? And what we really are missing here is, if you look at all the treat to target algorithms, there's nothing in there to say that you have to treat to a trough level. We're talking about getting our patients to clinical remission, steroid-free remission, endoscopic healing, and perhaps in the future histological remission as well. Nothing about treating to a trough. Again, we're not treating towards a lab value, we're actually treating towards getting our patients into healing itself. And the other component is if you're going to be checking levels, and you're doing some adjustments, and you're not going to be following them up, it doesn't really matter what you do, right? You really have to, whatever you do, if you check levels or not, if you dose adjust or not, follow them closely in a clinical follow-up and endoscopic follow-up to make sure we're treating to that target of true healing and rather just to a number itself. So general limitations, we know that we need more prospective studies. We need to better have an idea of how to interpret these results. And what we didn't talk too much about was out-of-pocket patient costs and variability of insurance coverage. These testing is actually quite expensive, and sometimes patients have to shell out big bucks to order these testing. And of course, it's not a point-of-care test. And we also need to know that we should be doing these levels at Trough. And in most cases, we need to be training our staff on appropriately ordering and timing of these tests as well, and not doing it at random times. Okay. So to conclude, I want to tell you that this is the perception of what Dr. Loftus is talking about and who he is. But reality, this is the real Ed Loftus. Having too much fun and making out with Dr. Bill Sanborn. So do you really want to believe me or him? In addition to some scientific research, I also had a reality check research team working for me as well, and these are Dr. Scott Lee and Dr. Scott Plevy doing some microbiota research on Dr. Ed Loftus Thank you. And Ed, I hope we're still friends, and if you have any issues with my slides, this is all I got to say.